All right, greetings. Welcome to session 3 of the Lurie Children's Pediatric Surgery Roundtable Series. In this session, we will introduce you to pediatric surgeon, Dr. Seth Goldstein, and APRNs, Susie Kuhava and Lurie Sands. They will be discussing the latest in operative and non-operative management for chest wall deformities. My name is Chad Worley. I'm your moderator, and I am the Lurie Children's Physician Liaison for the North Suburbs. I am the liaison, and I'm here with my liaison colleagues, Paula Nowak and Julie Kalkbrenner. But first, I would like to tell you, before we get going, I want to tell you a little bit about our presenters today. So Dr. Seth Goldstein is the co-director for Chest Wall Deformities Program and the program director for Surgical Simulation Program. He practices pediatric general thoracic surgery, as well as pediatric surgical oncology. He treats newborns, infants, and children with a wide range of conditions, including congenital and acquired diseases of the neck, chest, abdomen, and pelvis, traumatic injuries, hernia. Dr. Goldstein is also a surgeon scientist. He has authored over 50 peer-reviewed journal publications and 10 book chapters. Susie Kuhava is a pediatric nurse practitioner in pediatric surgery. Currently, she provides specialty care to patients with chest wall deformities in the outpatient setting. Susie serves as the chair of the APN Education Committee at Lurie Children's. And Lurie Sands is an advanced practice nurse specializing in the treatment and care for children undergoing surgery for a variety of acute and chronic conditions. She also provides care to the outpatient general surgery service with a special focus on patients with chest wall deformities. So a few years ago, our friends Susie and Lurie, they received the competitive Prince Scholar Award from Lurie Children's to grant funds for their analysis of pediatric reported outcomes measured in patients and undergoing surgical repair of pectus. So congratulations to you on that award a couple years ago. I'm sure you guys were very thrilled with that. So before I turn it over to our presenters, just want to remind you, for those who haven't been on the last few sessions, that to our community providers, our referral guide is coming up. So you'll get a full referral toolkit in the mail. And if you don't, for some reason, get one, just contact your liaison and we will bring one out to you. And as a reminder that all the referral information that you need for Lurie Children's is right at the Lurie Children's Physician Services webpage. And we have all the outpatient provider schedules, contact resources, pediatric specialties by location. And of course, we have our program library of these great events like we're having today. I would like to also remind you all that this session is being recorded. And we also encourage engagement during the session today. So please, if you have questions for our presenters today, please type them in the Q&A section. And after they are presenting, we will ask the questions for you. So please feel free to type in as many questions as you like, because we really love the engagement. So, but without further ado, let me turn it over to Dr. Goldstein, Susie, and Lurie. You guys can go ahead and take the screen back, and we look forward to hearing your presentation.
Okay. All right. Good morning, everybody, and thanks for joining us. I think that all of our team members can agree that the Chest Wall Deformities program has really been one of those if you build it, they will come situations. We sort of really ramped this up over the past 5 years, and we're really proud of all of the advancements we've been able to bring to Lurie and also to our patients and families. Right now, we have about 2,400 patients, which is a lot to sort of gain in the past 5 years. So that's been pretty incredible. And we've learned a lot along the way. And then just to sort of give you an idea of about how many operations we're doing in a year, it's around 100. So regionally, that is the highest number that you'll find in the area. So we're pretty lucky to have that nearby. There we go. This is a really quick overview that probably oversimplifies chest wall deformities, but I think it's more typical of what you're going to see in practice. So patients with chest wall deformities tend to be adolescents. It tends to be more common in boys over girls, but that is a little bit of an evolving statistic. On the left, what you'll see is a pretty classic, straightforward pectus carinatum chest wall deformity. And that's caused by a forward growth of the cartilage between the sternum and the ribs. So one of the things we're checking on those patients is if it can move when you push it. And then on the other side, on the right, what you'll see is a very classic, straightforward pectus excavatum chest wall deformity. And that just means sunken or caved in chest or funnel chest. It's actually just the opposite directional growth of what happens with pectus carinatum. So of course, those look really straightforward. We'll show you a slide a little bit later that kind of encompasses even more of what we see in our clinic. When you're sending a patient to us, what we typically do is go over a really comprehensive first visit. So that's looking at their medical history, the patient's surgical history, and the family history. And that's important because there are some genetic associations that can run with chest wall deformities. So it's a really detailed first visit. They're going to get a detailed physical exam, and then we're going to talk about education options for them, what we think they have diagnostically on clinical exam, and then we talk about kind of what's next for any patients who would benefit from some treatment. Recommendations for testing, and we put if indicated because not everyone needs all of these different levels of evaluation. We do recommend an echocardiogram for all of our patients who have a true chest wall deformity, and that's mostly for screening for possible valve or aortic root abnormalities that can be associated. For patients with pectus excavatum, and actually sometimes some of the other chest wall deformities that may need intervention surgically, we'd recommend a CT scan or an MRI. Of note, MRI is an option at some of our suburban locations. So for those patients who prefer to not haul downtown, we can sometimes get that done a little bit closer to home. And then one of the technologies that we have done in the past and currently is the white light scanner device. So you'll see that information on our website. It basically makes a 3D scan model that we can save and measure for an estimate of chest wall severity. It's not quite as accurate as CT scan or MRI, but it can be beneficial for tracking change over time. We do have a multidisciplinary clinic, so physical therapy is in the clinic with us almost always. And for patients who would need some treatment for pectus carinatum, we have orthotics in our clinics.
Okay, so I'm Lurie Sands. I'm the other nurse practitioner working in the chest wall deformities clinic. Susie briefly touched on pectus carinatum. And so pectus carinatum is pigeon chest or protrusion of the chest, as you can see highlighted nicely in these two photos here. What I like to say to families in clinic is if you think about pectus carinatum, where my thumbs are their spine, their ribs come around, cartilage, and then the sternum is where my fingernails are meeting. This cartilage is growing abnormally and it's pressing the sternum out. This is a perfect case scenario. Sometimes we see it off center. And so what we like to do in our clinic is to create a custom external compression device, fancy word for brace, with the orthotics department, where a brace wraps around their chest, placing pressure on the most prominent part of their chest wall deformity so that they can have a more normal appearing chest. The risks are very minimal. Some redness sometimes, a little bit of tenderness, Motrin or Tylenol help with that, but it's pretty well tolerated and it's usually very successful. If before bracing, all we had was the ravage repair, which is a surgical intervention to fix pectus carinatum, we save that for very severe cases, cases in which bracing is unsuccessful or unusual cases. So most of the time, we're very successful with just custom external compression device or bracing. We wanted to make this slide for you as kind of a reference slide so that you know when to refer patients and kind of what we're doing at each of these visits. When to refer. So pectus carinatum can be a really scary thing for these families. And we know that when you're meeting with them, knowing that they're in good hands is important. And we'll see them at any time. If they see a mass on their chest or their chest is popping out and, they want more education, we're happy to see them at any age. School age and adolescent age is usually when we'll start bracing just because that cartilage is still pliable and we can get good success with bracing. If they're 16, 17, 18, sometimes the cartilage has ossified at that time and bracing is not as successful. We offer custom external compression device bracing here at Lurie, where they make a brace to fit the patient's deformity with Velcro straps so it's more comfortable than, say, a commercial device such as Hanger Clinic or other clinics. But we have had some patients where insurance is prohibitive, and we will work with those families if that is the only option that they have. Timing of bracing, females, we do prefer to start a little bit sooner just because of breast development. It can be quite a challenge. And so if we can get them in a brace sooner before that happens, they're a bit more successful. Male patients, 12 years old, that's also due to maturity level. And we only want to brace one time, kind of like they think of dental braces now, where we just want to do this one time, be successful, and then we're done with bracing. We typically recommend overnight wear. Historically had been 24 hours a day, but we did find by using a temperature probe in the brace, by wearing it 10 to 12 hours a night, we're just as successful as 24 hours a day. They don't need to wear it to soccer practice, overnight camps, things like that. We want to make this as easy for the patients as we possibly can. We see them about every 4 to 6 months for assessments, kind of like dental braces, where we're doing regular checkups, adjustments as needed so that it's comfortable. And we do this all with our orthotics department so that we can do it at one visit. I would say most patients are successful with bracing in less than 2 years, some sooner, and it just depends on the flexibility or pliability of their chest wall and their wear time. So if they're more motivated to wear it and they wear it every night, they're going to be more successful than the patient that wears it a handful of nights a week. And now I'll turn it over to Dr. Goldstein to talk about pectus excavatum.
Okay, good morning, everyone. That is a really nice description of pectus carinatum, and I'm going to take you through excavatum because though that's the surgical side of thing these days, we have been so successful with the non-operative bracing for carinatum, for the chest out. For chest in, that ends up being surgical to correct that if it needs to be done. So there are all sorts of varieties of ways folks have considered changing the shape of the skeleton without surgery. But what we've learned from the bracing in all aspects is that you really need 8 to 10 hours a day. So it's probably safe for us to tell folks that physical therapy is a good thing, but it's not going to change the shape of their thorax. There are some interesting potential future ideas, like them here on the left-hand slide, some suction cups and vacuum bells, but they haven't really shown full efficacy yet. And so figuring out at what age, at what time, that's sort of future work. And then I show you these pictures in the middle on the right to let you know that that workup that was described is so important, because surgical repair of the chest wall is not for everyone. This is Cody Miller, an Olympic swimmer of Michael Phelps vintage, who you can see has an excavatum appropriately left alone. So we bear in mind that we aim to fix and correct pectus excavatum when we think it is or could in the future cause a restrictive pulmonary deficit. This is not a cosmetic operation. It's far too much for that. Next slide, please. And just like the carinatum, we tend to focus on the adolescents. You'll see this in your practices in many newborns, infants, toddlers, but those are not children for whom we should consider correcting the shape of the chest wall. So it's the picture on the right, which is our standard stock and trade. Now I'll tell you, you're welcome to refer families to our clinic for anticipatory guidance at any age, but it can help to decrease the anxiety and the wait time for the infants and toddlers if you let them know ahead of time that nothing is expected to happen until teenage years. Why is that? Next slide. Well, much like braces on the teeth, which you wouldn't put on before you lose the baby teeth, we've learned that altering the chest wall prior to adolescence can affect growth patterns and can leave teenagers and adults with pediatric sized chests for the rest of their life. This is a photo of me in training with Dr. Haller, who was a luminary in the field. And because it seemed easier and easier to repair the children at younger and younger ages, it was intuitive for him to do so, but he taught us his mistakes. And this is a photo of a really small thorax and a lot of upper sternal and clavicular overgrowth as a result of having a 6 or 7 year old chest into adolescence and adulthood. Next slide rather. So what do we do? And then one more advance, if you will. This is a CT cross section of what we see when we get this axial imaging of the excavatum, and you can see the sternum is depressed there in the middle. The mediastinum is all the way shifted into the left hemithorax. There's not a lot of room between sternum and spine there. And then this cartoon does a nice job of showing you the prior historic surgical repairs, which were break every rib and rewire them the way we like them, have been supplanted by and large over the past 2 decades by what we call a minimally invasive, though it's going through some high value real estate, minimally invasive placement of a stainless steel bar. So this bar stays there for 2 years while the adolescents finish their linear growth, finish their skeletal maturity, and then in a second operation, the bar comes out and they're left flat and straight with a good size of their thorax. Next slide. Technical details, which I'll share with you briefly, but it's fine to leave these things to me. But this is 2.5, 3 hours of general anesthesia and a great deal of care to keep the heart and lungs out of harm's way as we pass a bar through the mediastinum, and in the panel C there, you can see we put it in upside down, flip it over, it corrects the indentation of the chest. Next slide. Okay, this has been a disruptive game changer that we must tell you about, because 5 years ago, this operation was a 4 to 5 night inpatient stay with epidural catheter or similar. But in July 2020, we picked up a new technology, intercostal spinal nerve cryoablation. So through the same wound that I'm passing the bar and the help of a thoracoscope with the camera, we are freezing. We are applying a very deep freeze to the intercostal nerves, the nerves that make these kids ticklish beforehand and experience pain afterwards, rendering them numb for a good 2 to 3 months, and then full recovery with very low side effects in the way of paresthesias. And so by on both sides at multiple levels, freezing these spinal nerves, we've got our inpatient length of stay down to 1 night. And it almost could be a same-day ambulatory operation if all the ducks were in a row. It's remarkable. We still give them a few opioids and benzodiazepines for high-quality analgesia at home. Many of them tend to not need it. So that's been really disruptive in terms of not needing to keep folks out of school for weeks at a time, and has allowed us to really serve this community of chest wall deformities all throughout the year. Next slide, please. And even though our goal is not cosmetic, our goal is to fix the current or future restrictive pulmonary deficit, it does fix the chest. People like the way they look. This is a before and after. With the bar in, the indentation of the sternum is flat and straight. You can see those incisions in between nipple and axilla, and the same incisions are used to remove the bar 2 years later. Next slide. Folks forget about it. Having a bar in for 2 years is not a disability. It's a big surgery to recover from. We are very transparent about that. But beyond that, we get an annual chest x-ray, see that the bar is still in good position. And then we talk about growth charts and skeletal maturity and the right timing for removal. And hopefully that gives you a broad overview of the surgical correction of pectus excavatum. Next slide, and we'll wind down for you all. Not everything is the sticking out or sticking in. There are a couple unusual patterns. Sometimes ribs flare. Poland syndrome in the middle is an underdevelopment hypoplasia of the pectoralis major, shoulder girdle, and sometimes ipsilateral arm. And that's something that we evaluate and manage. And then there are a couple other very unusual patterns of the sternum. This one on the right is known as arcuatum or carinatum. Short sternum, some of which require surgical correction and others reassurance and expectant management. Next slide. Laurie and Susie, can I turn it back over to you? One more. Can I turn it back over to you to talk a little bit about our locations? Advance one more slide and tell everybody where we are.
There we go. Wait,
Go ahead.
Okay. So we are able to see patients at 4 different locations. At the downtown campus and at the Northbrook campus, we work closely with our surgeons, Dr. Goldstein and Dr. Abdullah. And then at New Lenox in Westchester, we also see patients, that's mostly Susie Kohava and myself, seeing patients at those locations. But we work closely with PT in those, all 4 of those locations, as well as orthotics.
Yeah, these are multidisciplinary clinics where we've worked really hard to have the physical therapists and the orthotists and ourselves there so that folks aren't making multiple appointments, multiple visits. And I think that combination of the team approach and being all throughout Chicagoland is why we're seeing about 1,000 patients a year. And as you heard earlier, about 100 adolescents with bar corrections annually. Something we've gotten really good at with dedicated intent and practice. Well, thank you all. And Chad, we're
ready to roll, ready to go for some questions.
Well, sure,
okay.
If you have any.
Yeah, we got questions flying in. So I'm going to go ahead and take the liberty of asking the questions for everybody here. So Dr. Taji, he asks, for newborn presentation, what can be done?
Okay, I'll field this. And a lot of the newborn presentations, we see a lot of concomitant with short NICU stays, ENT issues. Something about some of the deep intercostal accessory muscles breathing can give newborns an acquired pectus excavatum, and sometimes it's just congenital, it's hardwired. And the answer is nothing, because they don't need anything, because there is the pliability, the flexibility of the newborn chest is such that you cannot have a restrictive deficit from a pectus carinatum. So hopefully I wish we were in person to quibble about that and to hear if you have any thoughts otherwise, but the answer is just reassurance. No concerns for connective tissue disorders at that age. Many of them grow out of it. And even if you had a crystal ball and knew that they wouldn't, you wouldn't intervene at that age.
Okay. So Dr. Miner, he asked the same question that I was asking to myself is, can kids participate in sports when they have the bar in their chest op, post-op?
I defer to Laurie and Susie. Yes, tell us a little bit about our standard activity restrictions and recovery. That's helpful.
Okay. Yeah, so we see patients routinely until the bar comes out at 2 weeks, 3 months, 6 or plus or minus 6 months, and then annually until the bar comes out. And we get x-rays at each of these visits just to see if there's any rotation of the bar. That's the risk of any sport activity that you might want to participate in. But by 2 weeks, most patients are walking around. 6 to 8 weeks, patients are biking, conditioning, getting back into their teams. And then by 3 months, you can resume all contact sports. So we have really, serious hockey players. I've had patients rock climb. I've had patients, jump on a trampoline, and we have a very low bar rotation rate. I would say it's less than 2 to 4% is what I've been told. So we feel comfortable in managing that and following them with x-rays to make sure that bar doesn't move. But yeah, they can play sports. That was a long answer to that question.
Yeah,
but that's the right one. The swimmers are better. The volleyball players are happier. What were you about to say, Chad?
well, I was thinking like these, I mean, you've seen them. These kids are getting bigger and bigger now. The weights, the weightlifting and all the stuff that they have access to now. These kids are getting bigger and growing. Like, I bet you have to monitor that a little bit closer, don't you? Like with the bars?
Yeah, I mean, thanks for saying that. It's an art. I mean, the
I
whole
bet.
recovery, but the bottom line is that the material, the stainless steel bar, the materials we're using, and our physical therapy pathway and recovery. I mean, essentially, if they get 6 weeks out and then start to ramp up their physical activity, no, we've got all the hockey players, all the lacrosse players. Nothing is moving these bars, and they're feeling even better than before.
That's awesome. So Dr. Hawkness, we're going to go back to the questions now. So she writes, what do you do with rib flare? Should we refer?
You want that one?
Yeah, I'll jump in on this one. So this is sort of an evolving treatment modality, I'll say. I don't think there's sort of long-term experiential studies that prove that anything is super beneficial. So the first thing we do is have our patients see physical therapy in office if possible, because those physical therapists work with us for chest wall and scoli, and they're very familiar with all of that. That can sort of pull in the pectoral girdle and the abdominal musculature. On top of that treatment, we do recommend rib belting or sort of, some compression binding. Like I said, this is still kind of a new practice in chest wall world nationally and globally. So we're trying it here. I do think it's a good idea to refer those patients if they're open to meeting with us and learning what we're doing, because over time, we're going to see more what's working and what's not, and we'll be able to effectively, hopefully, impact those patients.
Okay. So, and then Dr. Dave Dopkin, he writes, what about college age patients who finally want to get their pectus fixed? Where should they be referred? How successful is their surgery?
Well, it's a great reminder that we will see all ages in our clinics. So no person, child or adult, is turned down for us to evaluate their chest wall deformity. I mean, once you've finished your growth and you have skeletal maturity, we all lose that childhood flexibility. Yes, it's a slightly different risk benefit calculation, but it's still a worthy conversation. I mean, the bottom line is, for a college age kid who I'm looking at, or young adult rather, I say, well, it's going to be harder for me and more painful for you. So let's talk about whether that would make sense. Let's talk about your activities of both daily living and your ability to exert yourself. And do you have dyspnea? And are we picking up, signs of a restrictive pulmonary deficit? And do you have any cardiac compression on echo? And so it's unusual for us to offer this correction to adults, but not unheard of.
Okay, so let me expand on that question a little bit, because I bet you it's popping up in some of those people's heads here, is that, Lurie Children's, we really just see up to 18 years old. So if the patient comes to you and they are older than 18 and they were not a previous Lurie Children's patient, they can still come to you with this issue.
They absolutely can. And not just in the ambulatory center, but we're the group that is asking our operating rooms and inpatient floors for the exceptions to any age limits. And so we have a pretty robust group of adults that get good care as they come through, even though it is not exactly what you think about in the freestanding children's hospital.
Right. Well, that's great. That is really great information. Thank you for sharing that. It's important. How about as a PC, at what point should they know it's cosmetic or medical necessity? That's probably a tough question to answer.
We're happy to do that for you. I mean, okay, if I had to give some gestalts, I would say, if you think that this is, noticeable at the pool, for instance, something that is not just a thin child, but this is excavatum, I'd suggest referring to us. We're pretty good at identifying marfanoid habitus, thinking about connective tissue disorders, getting an echo, making appropriate referrals. We pick up a lot of scoliosis, get our orthopedic surgeons involved. And not for everyone. It doesn't have to kick off anxiety. There's no time sensitive nature to it if you're in a PCP at a well child check. But I guess You can either let us do it, or you can know that we're going to dig deep into right heart filling, palpitations, dizziness, and or dyspnea on exertion history.
Okay, thank you. So Chris Speaker writes, looks like a multiple question here. What are the limitations of MRI in respects to pectus evaluation? Discrepancy in Heller index versus CT, availability of MRI. So I think you guys can see the question there. Avoiding radiation is preferred, obviously. So can you guys talk about that a little bit?
Do you want us?
Sure, please.
Okay. So is it on there? I don't see the question, so I'm going to do it based on what I remember. So we just, within the past 6 months, started using MRI. And I would say it's very useful. The images look very similar to the CT scan. And I would say the results are probably very similar as well. I don't know that we have enough data to say that CT versus MRI is better. MRI has the benefit of no radiation, and it has the benefit of being at different outreach locations. So they don't have to come all the way downtown, where CT, the only option is the downtown location. So I would say we're at this point in time, as of today, April 19th, trying to do more MRIs, and that could pivot. But for right now, we feel like it's been pretty useful, and our radiology department has been really, really good at working with us on getting this for patients. I hope that answers that question.
Thank you. Dr. Dopkin writes another question that's very interesting. So he says that Cincinnati Children's is very big on using the suction bell that you talked about earlier and non-operative RX, and has had some patients travel there for it. How far away are we seeing that as more of an option locally?
That's a good question. Since that's been brought up, let me give 30 seconds on the vacuum bell. The genesis of that is within the decade, coming from Germany. It isn't widely available in the United States. The idea is to apply a very large suction cup to the front of the chest and to wear it for as many hours as you can, hopefully while avoiding wounds and sucking the skin off the skeleton and things that you would think, well, that those could be side effects. I think we're still reasonably far from seeing that as what we recommend as a standard of care. From what I can tell in the literature, it's not really working great for the robust 14-year-olds that we offer the repair for. Sometimes you can pick up a very flexible 7 or 8-year-old that still has full childhood flexibility and straighten them out that way. But are the side effects at that age worth it for children for whom they might grow out of it anyway? So, and for what it's worth, when folks travel to Cincinnati or Boston, to the best of our understanding, they're still given the information of the folks that manufacture it in Germany and asked to procure it themselves, just as we will if folks have done that homework and are interested. I'm not averse to the idea. I just don't see it yet filling the need for the adolescents that we're seeing. It's a complicated question.
Yeah, I bet. Yeah, that's got to be a tough question. And Dr. Freed types in another question. Would you refrain from surgery if workup studies fail to demonstrate restrictive disease?
Yes, with caveats. So, someone that's not affected by their chest wall shape, we should start that conversation with a reluctance to surgically correct them. There are a couple of mitigating factors. The severity of the deformity. So if they are, sort of 8, 9, 10 out of 10 severity, then sometimes we offer them the guidance that even if they don't have that restrictive deficit at 15, Can they swear they won't have it at 45, 55, 65? That's just when we can see the deformity that profound. And the other is rapid progression. If the adolescent growth spurts are continuing, and we've watched the chest depress to a greater and greater degree, then we give folks the best crystal ball we have. In the context that we see, every clinic, there's a 25-year-old who wishes they'd come in as an adolescent and would like consideration. But as I've mentioned before, that's a harder consideration once you've reached adulthood. So that there is a lot of shared decision making.
Yeah, and it kind of goes back to some of the things that we talked about in the first two sessions of this roundtable is a great communication between the PCP and their patients with whatever issues that they're having. They should always be talking to them and communicating. So, for instance, if they turn 25 and all of a sudden they need this surgery, and they're regretting not talking about it when they were 16 or whatever the age was. It's really important for PCPs to have this relationship with their patients, so that we don't get to that point.
Second that.
Yeah. So there has been unbelievably great questions, you guys, that have been asked, and I don't see any more on the board here, but these questions have been very important and very good, which strikes me to think that a lot of them would probably want to meet you in person or even do a one-on-one video conversation with the three of you. You guys open for in-person meetings so we could kind of talk a little bit more and engage more with our friends here in the community?
Certainly.
Mhm.
For sure. That means we are in a post-pandemic era then.
Yeah.
Woohoo!
Yeah.
So for the community providers that are still on the line and you're interested in meeting either Susie, Lurie, or Dr. Goldstein, or all three of them, reach out to me or Paula or Julie, your liaison, and we can set up a meeting with them so we can expand more on this, because I would bet there are questions after they answered your questions. There's a lot of follow-ups here. I bet you a lot of you have. So feel free to reach out to us for these meetings. And then we're going to be sending you additional information on the chest wall program so you can learn more. But this is going to conclude our session for today. I really want to thank you all for your engagement. Dr. Goldstein, Lurie, Susie, you guys were wonderful. And thank you for joining us today.
Thank you.
And I want to remind everybody to join us later today at 12:30, where APRN Kate Chapman will be discussing gastrostomy tube. So I'm sure there's a lot of information out there that you guys are looking to hear on that one. So please join us. And I just want to thank everybody for joining us today, and have a wonderful day.
You too.